All right, hello everyone. We're going to start today by doing the mock exams for the anatomy. So Sana, I would start asking you some questions from different areas. So we're going to start by two scenarios for you. Every scenario will be 10 minutes, 9 minutes, and 1 minute at the end, just quick discussion. All right. So going to start by the first question. Can you tell me the blood supply of the thyroid gland?
Yes, the thyroid gland is supplied by superior and inferior thyroid arteries, and the superior thyroid artery arises from the external carotid, while the inferior thyroid artery arises from the first part of the subclavian artery.
Right. Is there anything else you would like to say about the blood supply?
While the venous drainage of thyroid is into the three veins, upper, middle, and inferior thyroid veins. In the upper and the middle thyroid vein drain into the external jugular vein, while the inferior thyroid vein drain into the brachiocephalic vein.
Okay. Sounds really good. Well done. So, like I said, is the first two things you said correctly. We can add thyroid artery in 10% of the population. Yeah,
Okay.
and the superior and the middle thyroid vein. Can you tell me lymphatic drainage of the thyroid gland?
Yes, the lymphatic drainage of thyroid gland is into the pretracheal, prelaryngeal, and paratracheal lymph node, while it is also drained into the upper and the middle deep cervical lymph nodes as well, and the brachiocephalic lymph nodes as well.
Okay, well done. Can you tell me the embryology of the thyroid gland?
Yes, the thyroid gland basically develops from the at the site of foramen cecum, that descends and runs forward from the hyoid bone, and it is at then it is placed in its adult anatomical position.
Okay, and can you tell me the abnormalities that can happen congenitally?
Yes, while in its descent, it can it cannot descend properly, then it can be as it can persist as the sublingual thyroid, or it can also if the tract does not occlude properly, it can also lead to thyroglossal cyst.
Okay, well done. So just very quickly, like I said, foramen cecum, and then passes forward and loop beneath the hyoid bone. And abnormalities is an incomplete descent, and it will be lingual or pyramidal thyroid, or incomplete closure, and that will be thyroglossal cyst. Well done. Can you tell me the vertebral level of the thyroid gland?
Yes, it is at the C4 to C6.
Okay, and the thyroid cartilage?
It is at the C4
Okay,
and C3.
well done. Can you tell me why does the thyroid gland move with deglutition?
Yes, because the thyroid gland is enclosed into the pretracheal fascia, while this same pretracheal fascia is also attached with the hyoid bone and the thyroid bone as well. When in the deglutition, when the hyoid bone moves, so it takes the thyroid gland and the pretracheal fascia as well.
Okay, well done, excellent. Can you tell me the possible nerve injuries that can happen with thyroidectomy?
Yes, during thyroidectomy, and both of the two branches of vagus nerve can injure. That is superior laryngeal nerve and the inferior laryngeal nerve, which is also called recurrent laryngeal nerve.
Okay, is there anything else?
In the nerves?
Yeah.
No, I'm not sure about anything else.
Okay, so external laryngeal nerve can be injured, and
Yes.
that will be close to the superior part of the gland. And the recurrent laryngeal nerve, like I said, can be injured, and that would be close to the inferior part of the thyroid gland, and also cervical sympathetic chain, and that will happen if there is occlusion of the inferior thyroid artery because the chain is supplied by it. And also, it would be good to add a few things in it, like external laryngeal nerve injury. You can start explaining here. Well, external laryngeal nerve can be injured toward the superior part of the gland, and this supplies the cricothyroid muscle, and the voice will be high-pitched voice, and recurrent laryngeal nerve will be injured, and you can add a few things to it. Okay. So
okay,
do you
I
know
have
the
a
cell?
question. I have a question.
Go on.
Whenever the examiner asks what are the nerves injured, do we need to just mention the names of the nerves, or do we have to explain these things as well?
To be honest, I would start by mentioning the names, and then we'll start elaborating unless the examiner stops me. So I'll say external laryngeal nerve, recurrent laryngeal nerve, and cervical sympathetic chain. And then I will continue by coming back to it. So external laryngeal nerve can happen this and this. If the examiner stopped me, great. If not, I'll just continue saying that.
Okay,
Can you
unless
tell me
the examiner stops us, we have to continue.
Exactly. Can you tell me the cell of origin of medullary carcinoma?
Yes, the parafollicular C cells.
Okay, well done. And what does it secrete?
They secrete calcitonin for the calcium hemostasis.
Well done. And where does the papillary thyroid gland spread? Sorry,
They spread.
papillary cancer.
Yes, they spread to the lymphatics.
So mainly lymphatic. Okay.
Yes.
Can you tell me the late complications of the thyroidectomy?
Sure. The hypocalcemia and hypothyroidism are the main late complications.
Okay. Why does hypocalcemia happen?
Because the parathyroid gland, the vascular supply to the parathyroid gland can be injured during thyroidectomy, or sometimes the whole of the parathyroid gland can also be removed during surgery.
Okay. Well done. Well done. Excellent. So we're going to move into your second mock exam, and it will be from anatomy. All right. From spine anatomy. Can you identify number 1 for me?
That's yes. That's basically the anterior arch of atlas.
And number 2?
That's the intervertebral joint.
And number 5?
Number 5 is the lateral mass of atlas, or the transverse process of atlas.
Can you say a final answer, please?
Transverse process of atlas.
Okay. And number 8?
Number 8 is dens.
Of what?
Of axis.
Okay. So I think here you've said 3 correct and 2, or maybe 2 correct and 2 are wrong. So 1, you said it correctly, and that is the anterior arch of atlas, and 2 is the atlantoaxial joint. So you see, this is the atlas up there, and this is the axis down there, and the axis extend upward by forming the odontoid process of axis. So this 2 is atlantoaxial joint. And you have number 5 is lateral mass of atlas. There isn't any transverse process in atlas. So basically, cervical vertebrae does not have transverse process. They have a spinous process, which is right there, and it's called bifid spinous process, but they don't have transverse process. All right. And the number 8 is the odontoid peg, or you can say dens of axis. All right. Sounds really good. Well done. Can you identify the signs on this X-ray?
There is fracture of the odontoid process, and there is
there anything else that you can see?
No, doctor. I can only see the fracture of dens.
Yeah. Okay. It's all right. So we have here odontoid peg fracture, which is right there, and we have malalignment, fracture edema as well as present. So all of these white tissue structure, this areas, there is some sort of hypodense areas in here. These are fracture edema all the way around the fracture, and most importantly, there is abnormal alignment of the between the atlantoaxial joint and also the dens and the atlas. So if you look here, the distance between the atlas on this side and the lateral mass is unequal to the other side as well. The other side is slightly bigger than this side, so there is abnormal alignment between the atlas and the odontoid peg. Okay.
Okay.
Good.
Thank you.
Can you identify one in this picture? Can you see it clearly, or do you want me to enlarge it?
Can you please magnify this?
One sec. I'll do that now. That's the maximum I can get. Sorry. 1.
Okay, that's the anterior arch of atlas.
Okay. What about number 7?
7 is lamina of C6.
Okay. And what about 4?
Of 4?
Yeah.
Okay, 4. That's hyoid bone.
Okay. Well done. Very good. So now you are 10 minutes. So I think we're going to continue for a few more minutes with you. But I mean, theoretically, you're done with your first station. Okay. Identify on number A. Identify number 2, please.
Anterior arch of atlas. Okay.
Can you say again number 2?
Can you please magnify a little?
All right. So let me. That is 2.
Okay. That's the anterior arch of cervical vertebra.
Okay. And what about number 3? 3 is right there.
Okay. That's the no, doctor, sorry.
It's all right. No worries. What about 5?
5 is the inferior articular facet.
Okay. What about 7? Right there.
Rather superior. 5 was the superior one. Okay. 7 is the posterior tubercle or the posterior arch.
Okay. You changed your answer in 5. Can you say again number 5? Final answer?
Yes. That's the superior articular facet.
Of what?
Of atlas.
Okay. So here I think we do. You missed number 3, and we need to do a bit of modification here. So you have number 2 is the facet of odontoid peg. This is not the anterior arch. The anterior arch will be sort of directing to here. All right. So this is the facet for odontoid peg, where the arrow ends. All right. Number 3 is an impression for vertebral artery. Okay. That's impression for vertebral artery. And number 7 is posterior tubercle. And number 5 is the lateral mass of atlas with the superior articular facet. So you said part of it, which is superior articular facet, but still, we need to mention that this is the lateral mass. Okay. So in C, on C, can you identify number 2?
That's the spinous process.
Yeah. And can you identify number 4?
That's dense.
That is dense. Well done. And number 7, right there.
Posterior arch.
Number 8.
That should be lateral mass.
Okay. So it's a bit different because here we're talking about the axis. So C is the axis. It's not the atlas, right? So 2 is the bifidus spinous process. Okay. And 4 is the odontoid peg. And 7 and 8 we're talking about lamina and the pedicle. So number 8 is the pedicle, and number 7 is the lamina. We don't call it posterior arch. So look at the difference. This is C1. This is C1, and this is C2. This one has a tubercle. This one has a bifidus spinous process. This one has a facet. This one has a odontoid peg, which is number 4. So the one with the odontoid peg will have a lamina and a pedicle. Lamina number 7 and pedicle number 8. All right. So
thank you.
Can you tell me about the ligaments attached to the odontoid process?
Yes. LR ligament, transverse ligament, and cruciate ligament.
All right. So transverse ligament, apical ligament rather than cruciate. There isn't a cruciate here. So apical ligament and alar ligament and transverse atlantal ligament. Okay, good. What are the ligaments between C1 and C2?
No, doctor. I don't know about those.
Okay, so ligaments between C1 and C2 could be something called anterior
Anterior.
atlantoaxial ligament and posterior atlantoaxial ligament and transverse ligament. I'm sorry, I don't have a picture here for it, but I mean, the aim of the mock exams is to test you rather than explain to you, all right? So anterior atlantoaxial and posterior atlantoaxial and transverse ligament. Okay, next question. What is the type of the atlantoaxial joint?
Pivot joint, synovial pivot joint.
Okay, what is the type of intervertebral joint?
Intervertebral joint. Saddle.
No. So atlantoaxial joint is a plain
Plane.
synovial joint. It's not a
Okay.
pivot. That's plain synovial. We have when you have two flat surfaces are coming together. That is a plain synovial joint. And the intervertebral joint is called secondary cartilaginous joints because you have the disc in between. So it's sort of like cartilage on one side, cartilage on the other side coming together. So we call it secondary cartilaginous joint. We have 4 more minutes for you. So what is the first cervical spinous process to be felt?
That's C7 vertebral spinous process because that's the largest one.
Okay. And why the others are not felt?
Because of the presence of nuchal line and the ligaments.
Okay, sounds good. So it's the nuchal ligament, not the line. So you have
Okay, nuchal ligament.
the largest process is the seventh process. That's why you feel it. Other processes are short and pepid. Remember when we saw number 2? It's very short and pepid at the end, so you can't really feel it. And also, there is presence of lots of soft tissue in this area, the muscles, and the superior nuchal ligament is what's more relevant as well. Okay, what are a typical cervical vertebrae that you know? What are the characteristics?
C1 is the atypical vertebra. C2 and the C7 is also atypical vertebra. C1 is atypical because it has 2 arches but not body and the lateral masses, while the C2 has a dance. That's why it is atypical. And the C7 does not have vertebral foramen, foramen that is in the transverse process, foramen transversorium, and yes, that's it.
Okay, well done. So we have here C1, 2, and 7. C1, no body, no spinous process. C2, the body projects upward and has a definite spinous process and a quite thick spine. And C7 has long spinous process and narrow foramen transversorium. That's why the vertebral artery enter through C6 transverse foramen transversum rather than C7. Okay, so we do have 2 minutes for you. Can you identify the following vertebra and explain to me why your answer? Explain to me your answer. Hello. Hello, Sana. Hello.
Yes, I can hear you. Can you hear me?
Yeah, I can hear you. Can you identify this vertebra and tell me why?
Yes, this vertebra is thoracic one because the body is heart shaped, and also there is also facet for the ribs, although I can't see.
Okay. No, no. So this is not thoracic vertebra. This is actually a lumbar vertebra, and the reason why it has a very big body that is kidney shaped. Okay. Number 2, it has triangular foramen. Number 3, and most importantly, it has very long transverse process. It's one of the longest. If you look here, this is the transverse process, and the spinous process is short and thick. When you compare it with the thoracic vertebra. Okay, so these are your reasons why this is a lumbar vertebra. So Sana, well done. You've done really well, and you answered most of the questions correctly. But I would advise you when you don't have an answer to something, I would advise you skip it rather than saying something that you're not sure about. Yeah, but well done. You've done really well. Okay.
Thank you.
Thank you. Can I guys ask you, whoever is in the meeting, can you please write to me if you are a participant? Can you write in the chat that you are a participant? Can everyone please here write in the chat if they are participants? Can you write? So we're going to start asking you. Is there anyone else in the Sana, can I ask you to close your mic as well?
Okay, sure. Wait.
Thank you. Can I guys ask you again, please, if you are a participant, write in the chat that you are. Okay. Is there anyone attending now who want to participate? Okay, Nazir, can I ask you please to open your mic and I'll start asking you.
Hello.
Hi, Nazir. Thanks for participating. So, Nazir, we're going to go back to sort of the head and neck. I'm going to ask you a few questions, if that's all right. So,
okay, but I just want to say you that I'm not well prepared because I was waiting for the next mock. So, but I will try to do my best.
No worries. Can you tell me the locations of parathyroid gland?
Yes, the parathyroid gland. There are two glands on each side on the lateral aspect of the thyroid glands.
Yeah, so you're right. There are two glands on each side, and they are in the posterior aspect rather than the lateral aspect. Yeah. Can you tell me the hormones secreted by the parathyroid gland?
Yes, the parathyroid hormone.
Okay, and it's important for calcium homeostasis. Can you tell me the embryology of parathyroid gland? Where do they come from?
Yes, the parathyroid gland, there is the superior and the inferior parathyroid. The inferior parathyroid gland, they come from the third pharyngeal pouch with the thymus, while the the superior come from the fourth branchial arch.
Well done. Can you tell me the blood supply of the parathyroid glands?
There is, I think, the superior thyroid artery and the inferior thyroid.
So the blood supply for the gland come mainly from the inferior thyroid artery rather than the superior, okay? So mainly from the inferior thyroid artery, which is a branch of the thyrocervical trunk. Okay, few more questions in the larynx. Can you tell me the nerve supply of the larynx that you know?
All the laryngeal muscles are supplied by the recurrent laryngeal nerve, except the palatoglossus. I think that it's supplied by the vagus nerve.
Can you say again?
I think that all laryngeal muscles or muscles of larynx are supplied by the recurrent laryngeal nerve, except the palatoglossus, which is
Okay, so it's all right. You're not sure about the answer, so I'm going to say it instead. So the nerve supply of the larynx is divided into sensory and motor, like anywhere in the body. You're going to divide into sensory and motor. So the sensory nerve supply above the vocal cords and below the vocal cords. So above the vocal cord, it will be. Does anyone know? Do you know? Above the vocal cord,
I remembered above the vocal cord, it will be the internal laryngeal nerve, and below the vocal cord will be the superior laryngeal nerve.
Below the vocal cord is the recurrent laryngeal nerve. Okay. Okay. What about motor supply? We're going to divide it. All the muscles are supplied by recurrent laryngeal, except cricothyroid muscle, which is supplied by external laryngeal nerve. All right. So these are the nerve supply that the larynx, like anywhere in the body, is sensory and motor nerve supply, and the sensory is above and below the vocal cords, and the motor is all the muscles except the cricothyroid muscle by external laryngeal nerve. All right. Can you tell me the attachment of the vocal cords? If you're unsure, just say it, and I'm happy to say it instead. All right. So can you tell me the attachments of the vocal cords?
Yes, there is 4 attachments, which is posterior. I remember. I think that inferior will be the creek.
It's all right. I'm gonna say that for you.
Oh yeah.
It's all right. So attachment of the vocal cord, you're going to have posterior attachment, anterior attachment, and lateral attachments as well. So posterior attachment is the arytenoid cartilage, and anterior attachment is the thyroid cartilage, and the lateral attachment GL muscles on the lateral wall of the cartilage. Okay, and the medial attachment is actually a free border. Okay, so I mean, if well, there isn't any image in here, but it's quite straightforward if you just Google it. So you have arytenoid cartilage posteriorly, thyroid cartilage anteriorly, and the laryngeal muscles on the lateral part of it, and medial border is actually free. Can you tell me the actions of vocal cord muscles?
Yeah, there is a muscles which is responsible for the opening of the vocal cords, which are the 2 posterior cricoarytenoid, while there are 2 muscles for the closing, which are the lateral arytenoid muscles.
Okay. Is there anything else that you know about the muscles? But well done, you've said it correctly. Is there anything else?
I think the opening of the posterior arytenoid causing just as a contraction and pushing the vocal cords to the outside.
It's fine. It's fine. You've said it correctly. So opening is posterior. The P go with the P, and closing is lateral cricoarytenoid muscle. And tensing the vocal cord, it happens with. Do you know which muscle? Tense the vocal cord. Get it a little bit tense.
No, I don't know.
It's a cricothyroid muscle. All right. The cricothyroid muscle get the cord tense. But you've said 2 of them, so well done. All right. So Nazir, can I just ask you, is there any particular part that you would feel comfortable more than the head and neck?
I think, the abdomen and pelvis.
Okay, so shall we go to the trunk? And I'm going to ask you in the trunk instead for maybe 5-10 more minutes, all right? So can you identify number 2 in this one?
Number 2, it is the celiac trunk.
Okay, so well done. So number 2 is the celiac trunk. There are many other structures, but for the sake of this mock exam, it's just number 2. So you have 2 of the celiac trunk, and you have like it gives many branches. Number 3, do you know number 3?
It is a common hepatic.
25.
25. I think
what
the left
goes
gastric.
to the other side? No. What goes to the other side, just behind the stomach, above the pancreas? The splenic artery. Well done. What is number 10? This is the common hepatic artery.
Yeah, it will give right and left gastric and cystic artery. So this is the left gastric.
No, sorry.
Right and left hepatic, and the cystic artery.
So one by one. So 2, you said celiac trunk. 25 is splenic artery. 3, the common hepatic artery. We'll go a little bit up by forming the hepatic artery proper. All right, and the hepatic artery proper will give right and left, but we can't really see it. Okay, good. Number 24. Do you know what number 24?
No.
So you have here the hepatic artery. 24 is on the lesser curvature of the stomach, and it's on the right side. No, so this is the right gastric artery. So it's in the lesser curvature of the stomach, and it's coming from the hepatic artery proper. So this is the right gastric artery. Do you know number 11?
11 will be left gastric.
Left gastric artery. Well done. So can you identify on this diagram number 29 and 30?
Yeah, 30 it will be superior mesenteric vein, 29 superior mesenteric arch.
Excellent. Well done. So artery and vein. I'm sorry, this is wrong. The marking are wrong. I'll just correct it later on. Can you here identify 1 and 10?
It will be the 10 will be the inferior mesenteric mesenteric artery and 1 inferior mesenteric vein.
Can you think again?
Okay.
So does 10 looks like a vein. It's very collapsed, but 1 looks like an artery, the big artery as well.
This is the aorta?
Yeah, I think so. That's the aorta.
Yeah.
What about 10?
The aorta, and this will be the inferior mesenteric, IVC.
Surprisingly, it's inferior vena cava on the other side.
Inferior vena cava.
Yeah. So big artery beside big vein. So that will be the inferior vena cava. So if you look here, we sort of took all these structures and raised them. So can you see number 1 here? So this is the aorta, right?
Yes.
That's number 1. So we removed all these structures, elevated them up, and now you're looking here. Okay, so this is the pancreas you're looking at. So this is 1, and this is 10. And we also removed the superior mesenteric and vein and artery. Okay, can you here identify number 5?
Yes, number 5, it will be the inferior mesenteric artery.
Okay, so 5 is the inferior mesenteric artery. Can I ask you to say number 6 as well?
Yeah, number 6, it will be the left colic artery.
What about 14?
It will be sigmoid branches. Sigmoid artery.
What about 17? 17 is right there.
Yeah, it is superior rectal artery.
Well done, Azir. I like that. So inferior mesenteric artery, like I said, is 5, and the others we've covered them as well. I'm sorry, these markings are incorrect. I'll just correct them later. Okay. So what is the surface marking of the aorta that you know?
Yeah, the aorta, it starts from the level of the T12 and bifurcate and L4. It's just 4 centimeters above the transpyloric plane, which transpyloric plane, it is a line from the jugular notch to the symphysis pubis.
Okay.
I think
anything else? You've said the proximal point, how to find that. What is the distal point? Transcrestal line or intercrestal line? Remember that? So you mentioned T12 to L4, correct? Where to find T12? It's 4 centimeters above the transpyloric plane. Where to find L4? That's the rest of the answer. It's an intercrestal line between the iliac crest on both sides. And you mentioned very well how to find the transpyloric plane. Okay?
Yes.
So we need to find point A and then point B and then connect it. That will be the artery. Can you give me the branches of the abdominal aorta?
Yeah, there is a unpaired branches and there is a paired branches started from the T12. The unpaired branches will be the celiac trunk, and the paired branches will be the right and left inferior phrenic arteries, middle phrenic arteries, and the L1 will be the unpaired branch superior mesenteric artery, and the paired branch will be right and left suprarenal, and L2 will be only paired branches, right and left renal. Then L3 will give the inferior mesenteric artery unpaired, and the paired will be the right and left gonadal. And the L4 will be the unpaired will be the posterior branches, which is the median sacral artery. And also there is a lumbar branches from L1 to L4, also a posterior branches.
Okay, sounds good. So everybody has his own way. To be honest, I prefer branches from the anterior surface, from the lateral side, from the posterior surface, and terminal branches. Okay, it's really up to you. What you said is absolutely correct. I agree with you, but I think I prefer this way. It's easier for me. So from the anterior surface, there is celiac trunk, superior mesenteric artery, inferior mesenteric artery, and the levels as you see. Okay, from the lateral side, you have the inferior phrenic artery at T12, the middle suprarenal at L1, the renal artery at L2. The posterior branches, you have the lumbar branches, the gonadal branches, and the median sacral branches. Terminal branches is 2 common iliac branches at L4. To be honest, I personally feel that this is easier to remember than paired and unpaired. You might miss a few things, but anterior surface, lateral side, posterior, and terminal. So we're covering the aorta from all the way around. Okay, so it's really up to you. There is no problem at all. Can you tell me the anterior relations of the abdominal aorta?
Yes, first the celiac trunk, number two the superior mesenteric artery and the body of the pancreas and the splenic vein and the left renal vein and the root of the
Okay, well
mesentery.
done. Yeah. So again, the way I remember it, it's a great what you said. 4 vessels, 2 organs, and 1 mesentery. The vessels are celiac trunk, superior mesenteric artery, left renal vein, splenic vein. You have 2 arteries and 2 veins as well. The organs, like you said, the pancreas and the second part of the duodenum and the root of the mesentery at the end. So 4 vessels, 2 organs, and 1 mesentery. That's the last diagram for you. It's quite an easy one. So, and then we're going to shift to the next. All right. So, can you identify A in this one?
Yes, this abdominal aorta.
What about B?
B, it will be the right the right iliac artery.
The right common iliac artery, because you have external
Sorry,
and internal iliac, right? What about
yeah,
C?
the left common iliac artery.
What about D?
D, it will be the left renal artery.
What about E?
E will be the right renal artery.
What about F?
It will be the splenic artery.
What about G?
G will be the common hepatic artery.
Excellent. What about I?
I, it will be the gastroduodenal artery.
Well done. What about J?
J, it will be the left hepatic artery, and K will be the right hepatic artery.
Well done. That's excellent. So now I think you're quite comfortable with the branches of the aorta and the celiac trunk as well. Well done. So thank you very much, Nazir, for stepping in. That was really good.
Thank you.
Who is next? Saniha, I'm not really sure if I'm saying the name correctly. I'm sorry about that. But do you want to come open your mic for spine?
Yes, sir. Sneha here.
Okay. All right. So we're going to ask you about spine. I'm sorry, Saniha. Can you be in a quieter place, if that's all right?
Sorry, sir?
Are you, I mean, there is a lot of noise around you, but I think it's better now, so that's fine. So we're going to continue with the spine. Can you tell me the structures passing an intervertebral foramen?
Yes, sir. The structures passing through intervertebral foramen are the spinal artery of the segmental artery, the communicating veins of the internal and external plexus, and the recurrent meningeal nerve, and the root of each spinal nerve, and the dorsal root of ganglion, and the transvertebral ligament.
Yeah, it's called transforaminal ligament, but well done. You've answered, yeah, most of them correct. Dorsal root ganglia, root of spinal nerve, recurrent meningeal nerve, and these are 3 nerves, right? And then transforaminal ligament and 2 vessels, spinal arteries, and communicating veins between the internal and external venous plexus. Okay? Well, at which level will you do a lumbar puncture?
At L4, L5.
Okay. And what are the layers that the needle passed through?
The layers we need to pass through are skin, subcutaneous fat, supraspinous, interspinous, ligamentum flavum, epidural space, dura mater, subdural space, arachnoid mater, and subarachnoid mater, where we will find the CSF.
Subarachnoid space. Well done. So you've said it very well. So you can just mention the fascia, and when you're saying supraspinous, just say that it's a ligament, supraspinous ligament. And when you say interspinous, just say interspinous ligament and flavum, and so on. But well done. Can you tell me the movements of the lumbar spine?
Yeah, the lumbar vertebrae can perform flexion, extension, axial rotation, and lateral flexion.
Okay, well done. Can you tell me the levels of the spinal cord in a newborn and an adult?
In newborn,
or
the
in other words,
spinal cord. In newborn, the
Go on.
spinal cord ends at L3 level, and in adults, it ends at L1, L2 level.
Okay, well done. So yeah, obviously in a newborn, it will be slightly longer, so it ends at L3. But in an adult, as you go taller and taller as you grow up, it will be sort of the same size. So it will be at L1, L2. Okay. Can you tell me the contents of a spinal canal below L2?
Sorry,
It's
conus
phylum
medullaris.
terminale or phylum
Yeah,
terminale
phylum
and conus
terminale
medullaris.
and
Yeah.
conus medullaris.
Yeah, I'm sorry, it's not ligamentum phylum. That's completely wrong. I need to edit this, so let me just edit it now. So yeah, so it's conus medullaris and phylum terminale. All right.
Yeah.
Okay, well done. Can you tell me the location
Sir,
of the
chorda equina,
paravertebral?
I guess. Phylum terminal and chorda equina.
It's a conus medullaris is still there as well, but that's fine. I'll look into that. Yeah.
Yeah. Okay.
Can you tell me the location of the paravertebral venous plexus?
It is located around the vertebral body. There are 4 paravertebral venous plexuses. First, it is external and internal, and then again, each of those are divided into anterior and posterior paravertebral plexuses. The anterior external paravertebral plexus is situated around the outer body of the vertebra, whereas the posterior external plexus is surrounding the spinous process of the vertebra, and the anterior internal plexus is runs vertically and anteriorly to the dura mater, and the internal posterior plexus runs posteriorly to the dura mater.
Okay, that sounds really good. But the way I would say it, just simply make your answer very short. I would say external and internal venous plexus, external anterior, and they are located anterior to the body of the vertebra, and posterior, just posterior to the spinous process, and internal, you have anterior and the posterior as well. So anterior is just anterior to the dura, and posterior is posterior to the dura. All right, that's what you really need to say. Okay. Can you tell me about some tumors that metastasize to the spine?
Yes, the most common ones are breast tumors, lung tumors, prostate tumors, urinary bladder tumors, and rectal tumors.
Okay. So the way I divide it, you said it correctly, but I would like to divide it in this way. You have some lytic lesions that go into the spine and some sclerotic lesion. Do you know what a sclerotic lesion will be in the spine? Or which tumor that can cause sclerotic lesions?
Sorry, sir, I don't know.
Okay, that's fine. So lytic lesions are the common one, and that would be the lung, the breast, the melanoma, lymphoma, GI, multiple myeloma, thyroid, and renal. But the only one that causes sclerotic lesions is the prostate cancer. When you come to the pathology section, you will find this question being asked. So that's why I thought it's better to combine them. So prostate is the only sclerotic one, but otherwise would be lytic lesions. Okay. This question is fine. You can just demonstrate it later on. Can you tell me structures that are found at C6?
Yeah, there is the termination of pharynx and the origination of esophagus, and termination of larynx and origination of trachea. The vertebral artery enters the foramen, transverse foramen of C6 vertebra, and the middle thyroid vein exits. A middle thyroid artery.
We don't have a middle thyroid artery.
Middle thyroid vein enters the thyroid gland, and inferior thyroid vein exits the thyroid gland, and the inferior belly of omohyoid crosses at the C6
Yeah,
level, and
yeah. So it's all right. You've said enough at this point, but I just gonna correct you a little bit. So we have the pharynx and larynx at this level. So pharynx into esophagus, larynx into trachea, and you have some arteries. Okay, so the vertebral artery enter foramen transversum at C6, and the superior thyroid artery enter the thyroid gland. Middle thyroid vein leave the thyroid gland, and the cricoid cartilage and intermediate tendon of omohyoid muscle. All right. So yeah, I think you
okay.
covered most of them. It was just the artery and vein. Which artery and vein? So the vein is the middle thyroid vein, leaves the gland, and the superior thyroid enters the gland. All right. Good. Yeah. So that is the spine. Is there anyone else who want to participate today? Anyone else who wants to participate? Okay. If not, we can end the meeting today. But if anyone else want to participate, please say in the chat or open your mic and let me know. All right. Do you want to open your mic?
Yes.
All right. Thank you for stepping in. Before we start, do you have any branch in particular that you wanna do today, or shall I just ask you randomly?
You ask me randomly. I'm not well
Randomly,
prepared.
okay. All right. So I think I'm gonna leave the upper limb for the next time. So we can just crack on with maybe trunk and thorax. Um, just a few questions. Um, so this is a CT angiogram. Can you tell me the abnormality that you can see?
This is a angiogram, where there is a dilation of the abdominal aorta.
Can you say again?
Dilation of the abdominal aorta.
Okay. And that's it. Is there anything else you want to say?
Aortic aneurysm.
Okay, so if you can see here, this is the abdominal aorta, and it's very dilated, and there is sort of extravascular blood in here as well. So it looks like an abdominal aortic aneurysm, and it is an infrarenal because you have the kidney here. So the blood supply to the kidney has went off already. So it's an infrarenal abdominal aortic aneurysm. All right. So can you define an aneurysm to me?
The dilation of the artery.
Okay. So yeah, define aneurysm. It's an abnormal dilatation of an artery. And usually, to give the answer correctly, that exceeds the normal diameter by 50%, right? So if the normal diameter of the aorta is 1.5 centimeter, if the size is more than 2.5 to 3, that will be a dilated aorta, and you will call it an aneurysm. Can you tell me the pathogenesis of abdominal aortic aneurysm?
Pathogenesis is usually there may be two aneurysm and false aneurysm, and due to repetitive trauma, uh, there is false aneurysm due to collection of blood into the tunica, intima and media, and in true aneurysm, there is the pushing of all layers of the due to the weakness of the tunica media or cystic medial necrosis, central medial necrosis.
Yeah,
No, cystic
yeah. I
medial.
mean, yeah, you covered most of it. So it's mainly due to median cystic necrosis and due to loss of intima and the elastin from the media. So weakness in the intima and the media that will lead to weakness in the wall and consequently an aneurysm. Can you tell me some of the causes that you know for an aneurysm?
Uh, there may be a Marfan syndrome, there is cystic medial necrosis and aortic aneurysm. There was repetitive trauma, hypertension, atherosclerosis, and diabetes mellitus.
Okay, so well done. So you just mentioning the risk factors for an aneurysm. So the question is asking you specifically about the causes of an aneurysm, not the risk factors. So the risk factors include diabetes, hypertension, and hyperlipidemia and atherosclerosis and all these kind of things. But the direct causes for an aneurysm is one, atherosclerosis. That's the commonest one. All right. So 90% of an aneurysm would be atherosclerotic. You have infection like mycotic aneurysm or congenital weakness in the wall, and that happens in some patients with any connective tissue disease, and also Marfan syndrome like connective tissue disease as well. So atherosclerosis is the commonest infection. We call it mycotic aneurysm. Infection could be fungal or bacterial, viral, and you have congenital and connective tissue disease. All right. Can you define a dissecting aneurysm?
No.
So dissecting aneurysm is not a true aneurysm, it's a false aneurysm or a pseudo aneurysm that happens due to injury of the endothelial layer, and the blood will track just below the intima over the media, and it will lead to some sort of semicircular dilatation on one side of the artery, and this is called aortic dissection. All right. So basically, you had dissection in the endothelial layer, and then tracking of the blood in the wall, and this is not a true aneurysm. So the difference between a true aneurysm and a pseudo aneurysm, true aneurysm is weakness of the three layers of the artery, but pseudoaneurysm is actually just an injury to the endothelium with tracking of the blood. All right. So separation of the layers of the arteriole with propagation of dissection maybe proximal and distal. All right, that's fine. Can you identify number 39 here? I think I'm sure it's quite difficult to find 39, but let me try to find it for you. 39 is just right there. So this is 39. I can get the image a little bit smaller for you just to get one. One sec. Just let me get the image again for you. So I'll get it a little bit smaller, just so you can see the whole thing. So 39 is there, all the way down like that.
39. 39 is the ureter.
What about 40?
40 is the ureter. Oh, sorry.
Yeah, exactly. So 40 is going to the bladder. This is the ureter, right? What about 39?
39 would be nerve. The ilia.
39 is there as well. Look, it's there as well. Very nice on the other side.
Oh, 39. No, sorry.
Yeah, so 39 is gonadal artery, right? Or gonadal vessel. To be honest, 39 looks like gonadal vein, not an artery really, because this is the inferior vena cava is number 23. So this is right and left gonadal. The other trick is that I can tell you. So we do dissection, and usually we inject the vein with a blue dye. That's why this is the vein, and an artery with a transparent dye. All right. So when we do dissection, we start injecting the veins for teaching purposes to get them clear. So this is a vein. 23 is a vein. That's the inferior vena cava. Number 8 is a vein because we injected it. Because this is a dead body, right? That's not a live body. So we inject it with sort of blue dye to make sure that this is a vein. So 8 is a vein, which is the common iliac, right? 8 on both. Actually, that looks like the external iliac is number 8, right? And 4 is the common iliac artery on both sides. And this is the inferior vena cava. And there is a big vein on this side, which is number 39. So this is gonadal vein, not gonadal artery. I'm sorry about that. I'm going to change it. So this is gonadal vein. All right. And you don't need to specify whether it's right or left, because this is the right one, and the left one again is 39 as well. So you don't really need to specify. Yeah, sounds good. Let's talk a little bit about the tributaries of the inferior vena cava.
So the tributaries are paired inferior phrenic vein and the hepatic vein, the right suprarenal vein, renal vein,
gonadal vein, and lumbar vein, the common iliac veins, the origin
Yeah.
at the lumbar.
Yeah, so two common iliacs. If you look here, you have two big common iliac veins coming into the inferior vena cava, and also the gonadal vein that we mentioned a little bit early. So those two will definitely drain into the inferior vena cava. You have here the organs that you have is the lumbar. I mean, all the viscera. So lumbar veins. I'm sorry, not arteries. Lumbar veins will drain into it, and also the two suprarenal veins will drain into it, and the two renal veins will drain into it, and the
Right
common iliac veins.
will be tributaries. The left will be
Sorry,
drain into left.
yeah. So you have here the renal. Two renal veins will go there, but the right suprarenal vein only, not the left suprarenal. Sorry about that. I probably need to change a little bit in these. Yeah, so common iliac veins and two renal veins and right suprarenal vein and the lumbar veins and gonadal vessels on both sides and the hepatic as well. Okay. Yeah. Well, coming to renal veins, can you tell me the anterior relation of the renal veins?
The renal, right renal artery, no, the abdominal aorta.
Which one is anterior to the aorta? I mean, actually, do you think the vein is posterior to the aorta or anterior to it?
The anterior to the aorta.
Yeah, exactly. So you wouldn't say it here, right? You have the right is related to the second part of the duodenum, and the left is related to superior mesenteric artery, splenic vein, and the body pancreas. I'm sorry, your voice is really interrupted. I can't hear you well.
Now, are you clear?
Yeah. So yeah, again, so the right, you have the second part of the duodenum on the right side, and the left side you have superior mesenteric artery, and the splenic vein, and the body of the pancreas related to it as well. Okay. Well, I think you've done enough. Is there anyone else who want to participate today? Thank you very much for stepping in. Is there anyone else who want to participate today? It's absolutely fine. If there is no one, we can end the meeting. So it would have been 1 hour today, and maybe next time we can arrange for another session. If anyone wants to participate, please raise your hand or just write in the group chat. I'll give you maybe 1 minute, and if not, we can end the meeting today. All right, no worries. Thank you, everyone, for coming in today. So what I'm going to do is I'm going to share the recording with everyone so everybody can get the best out of it. Thank you very much for your time.
Thank you.
Thank you.